Okay, picture this. You're doing a routine cardiovascular exam. You uncover the patient's chest, and right there, tucked neatly under the left clavicle, is this small, unmistakable bulge with a surgical scar over it. Well, on one hand, your job just got a bit easier, right? You know exactly why you're being asked to examine their heart. But honestly, it also just got a whole lot harder.
You're probably thinking, why harder? Well, because now you have to figure out what actually lies beneath that clavicle scar. See that single, identical-looking little external clue? It could literally belong to 4 completely different devices, doing 4 entirely distinct jobs inside the body. And mixing them up, whether you're standing in front of an examiner or, way worse, making a real-time clinical decision, is a super common yet totally avoidable mistake.
So let's dive into this. If we want to avoid that trap, we've got to stop trying to memorize a massive laundry list of device names. Instead, let's just go back to first principles. Basically, a diseased heart can have one of 4 fundamental problems. 1, it beats too slowly, that's bradycardia. 2, it suddenly triggers a lethal fast rhythm, like a ventricular arrhythmia. 3, it beats completely out of sync, which is dysynchrony. Or 4, the pump just mechanically breaks down altogether. 4 problems, 4 solutions. Once you match the right device to the underlying problem, the why do they have this question basically answers itself.
Let's start with the first one. Section 1, the pacemaker, fixing a slow heart.
This is our solution to the too slow problem. Think of the pacemaker as an internal watchguard. It senses when the heart's natural electrical activity is falling short and fires off a pacing stimulus to keep the heart rate safe and steady. You're going to need one of these when the atria and ventricles literally stop talking to each other reliably. And we're talking about irreversible conduction blocks here, not something temporary like a drug effect or ischemia. So things like second-degree Mobitz type 2 AV block, high-grade AV block, and third-degree or complete AV block. The unifying logic is actually super simple. If the heart's natural wiring is permanently broken, you just have to install an artificial substitute.
Moving on to the next problem. Section 2, the ICD, stopping lethal fast rhythms.
Now, the implantable cardioverter defibrillator, or ICD, solves a totally different beast of a problem. Instead of just prodding a slow heart to beat, it acts as a constant monitor for sudden, lethal fast rhythms. We're talking ventricular tachycardia or fibrillation, and it delivers an instant shock to stop it in its tracks. Now, clinically, there are 2 distinct scenarios for an ICD, and it's vital to keep them separate in your head. First up is secondary prevention. This is for a patient who has already survived a documented ventricular arrhythmia, and they have a reasonable life expectancy of over a year. You're literally just trying to prevent it from happening again. Then you have primary prevention. These folks haven't actually had an event yet, but statistically speaking, their risk is dangerously high.
Okay, so who exactly falls into that primary prevention bucket? Well, the absolute magic number to drill into your brain here is 35%. We're looking for patients with symptomatic heart failure, so usually NYHA class 2 or 3, who have an ejection fraction of 35% or less. But wait, here is the absolute most crucial part. This has to be despite at least 3 months of optimal medical therapy. That 3-month waiting period? It matters immensely. It proves that the weak ejection fraction is genuinely stubborn and refractory to the best guideline-directed meds we have, not just a temporary slump that might bounce back with a little more time and the right pills.
And speaking of timing rules, let's look at this heavily tested number 40. You absolutely must avoid implanting an ICD within the first 40 days after a myocardial infarction. Why? Well, right after an MI, the risk of a ventricular arrhythmia spikes, but it's often totally transient. Meanwhile, the complication risk from early device surgery is disproportionately high. So a lot of patients who might look like they qualify on day 5, they really just need to be reassessed after that 40-day window closes, rather than getting an immediate permanent device.
Now, you might be sitting there wondering, where are they getting these hyper-specific percentages and waiting periods from? Well, they're firmly grounded in the comprehensive latest 2025 ACC/AHA multi-society appropriate use criteria for ICD, CRT, and pacing. It's this exact multi-society guidance that dictates who gets these devices. It basically ensures that every single implantation is backed by the most robust, up-to-date evidence out there.
Next up on our list, Section 3, cardiac resynchronization therapy, or CRT. Restoring synchronized contraction.
So CRT, this uses 3 or more leads to fix the dyssynchrony problem. That's when the ventricles are contracting in this messy, staggered sequence instead of a nice, simultaneous squeeze. That dyssynchrony basically ruins the heart's pumping efficiency, completely independent of any underlying muscle damage.
So who gets their ventricles resynchronized? The classic guidelines look for patients with an ejection fraction below 35% who also have a wide QRS complex, specifically over 130 milliseconds. Historically, the absolute slam dunk benefit is seen in patients with a left bundle branch block, or LBB, and a really wide QRS of 150 milliseconds or more. But here's a fascinating evolution in the field: conduction system pacing. Doctors are now pacing directly at or near the His bundle or the left bundle branch itself. It's emerging as a huge alternative to traditional biventricular CRT, especially for patients who don't have that classic LBB pattern.
Finally, the last piece of the puzzle. Section 4, the LVAD, substituting the failing pump.
Okay, so those first three devices, they were all electrical solutions. But what happens if the problem is purely mechanical? The left ventricular assist device, or LVAD, solves a completely different issue for a failing heart when medical therapy has basically hit its limit. An LVAD is quite literally a mechanical pump that pipes blood straight from the left ventricle to the aorta, and it's amazing how the indications for this therapy have genuinely evolved. Originally, it was almost exclusively used as a bridge to transplant, temporary support just to keep someone alive until a donor heart became available. But today, it's increasingly used as destination therapy, because the devices are so much more durable now, and LVAD can be a permanent, potentially lifelong alternative for patients who just aren't candidates for a heart transplant.
But as you can imagine, swapping out a biological pump for a mechanical one brings its own unique set of complications that you absolutely must watch for on exam. Since LVAD normalizes or even boosts venous return, a weak right ventricle can just get overwhelmed and suddenly decompensate, leading to right heart failure. You've also got to watch for blood clots in the pump, driveline infections because you have a permanent breach in the skin, plus strokes and acquired aortic regurgitation. And actually, here's a wild one: gastrointestinal bleeding. The continuous flow mechanism of the mechanical pump actually shears the blood proteins apart, creating acquired von Willebrand factor abnormalities. Pretty crazy, right?
All right, let's tie it all together. Section 5, the bedside device detective, synthesizing the findings.
So how do we actually pull this whole picture together in practice? Let's walk through this definitive cheat sheet. If you examine a patient, spot a clavicle scar, and see absolutely nothing else, you're choosing between a pacemaker, an ICD, or a CRT. From the outside, they can look 100% identical. To figure out which one it is, you've got to get a chest X-ray. A pacemaker is typically going to show 1 or 2 leads with no shock coil. An ICD, that will proudly show off a thicker, visible defibrillator shock coil on the lead. A CRT device will characteristically have 3 or more leads to synchronize those ventricles. Now the LVAD, that one announces itself loud and clear at the bedside. You're not looking at a tiny clavicle scar, you're seeing a massive sternotomy scar, a driveline cable coming right out of the skin, and external battery packs. And on the X-ray, no electrical pacing leads, just a big old mechanical pump.
So there you have it. By zooming out to first principles, asking if the heart is too slow, dangerously fast, out of sync, or mechanically failing, these devices stop being just some random list to memorize, and they become a highly logical set of clinical solutions. If this explainer helped clear up the whole clavicle scar mystery for you, definitely hit that like button, drop a comment, ask any questions you might have, let us know what topics you want us to cover next, and consider subscribing to the channel for more. But before you go, I want to leave you with a quick challenge. The next time you uncover a patient's chest and see that identical-looking scar right under the left clavicle, ask yourself, which of the 4 problems could that heart not solve on its own?